Hello, my name is Gustavo San Roman, and I would like to thank you for taking the time to view this presentation. In order to create a cesarean birth measure that doesn't have case mix flaws like the NTSV case mix, and more importantly accounts for the inherent risk of the women who are giving birth, I started with three simple suppositions. First is that the majority of pregnant women will attempt labor with the goal of achieving a vaginal birth. Second is that the pregnant women who do not attempt labor presumably schedule a cesarean birth as the result of a well-informed discussion with their obstetrical care provider. And third, if one assumes that all of the scheduled cesarean births are appropriate, then the only way to decrease the cesarean birth rate is to study the women who labor. Therefore, my case mix includes only women who attempt labor with a singleton baby in vertex presentation between 37 and 42 weeks without a history of a prior cesarean birth. Comparing this case mix to the NTSV case mix reveals that this case mix will not include patients with conditions like placenta previa or any other condition that results in a scheduled cesarean birth. Unlike the NTSV case mix, my case mix is not limited to nulliparous women. This case mix will include approximately 2/3 of all women who give birth. Keep in mind that from this point forward, that all data and results in this presentation will refer to only women who meet the criteria for this case mix. The most important rule when creating a cesarean birth measure is that labor is a physical process, and the risk that this physical process will end in a cesarean birth is determined by both inherent risk and applied risk. Since this is the most important rule, I am going to say it again. Labor is a physical process, and the risk that this physical process will end in a cesarean birth is determined by both inherent risk and applied risk. So if we look at this rule as a math equation, we see that a woman's risk for cesarean birth during labor is equal to her inherent risk times the applied risk, and keep in mind that the applied risk can either increase or decrease the inherent risk. These are the 7 most important physical characteristics for determining inherent risk for women who will labor. In order to prove this, I analyzed the outcomes of 284,156 women who labored in New York State with a term singleton vertex pregnancy without a history of a prior cesarean birth. The data represent the outcomes achieved by 2,915 obstetrical care providers working out of 109 hospitals. The first physical characteristic is parity. Women with at least one prior vaginal birth decreased their rate of cesarean birth from 25% to 5%. Since parity is such an important factor, analysis of the physical characteristics will be divided by parity into either nulliparous or multiparous. The next physical characteristic, fetal weight, is interesting in that, as expected, increasing fetal weight increased the rate of cesarean birth, but only when the fetal weight was above 2,900 grams or 6 pounds 6 ounces. When the fetal weight is less than 2,900 grams, it is decreasing fetal weight that increased the rate of cesarean birth. This nonlinear association was similar to that found by Dr. Chen's group in Florida. With initial body mass index, you can see that the rate of cesarean birth for first-time mothers was about the same as their initial body mass index. Maternal age is next. Note that only 16% of the 18-year-old first-time mothers had a cesarean birth, whereas that number increased to 30% for our 32-year-olds and becomes 40% by age 40. Next, we have maternal height. 24% of first-time mothers who were 5 foot 4 inches tall had a cesarean birth, whereas being 4 inches shorter increased that percentage to 32%. The next physical characteristic is gestational age, and note that increasing gestational age increased the rate of cesarean birth. The last physical characteristic is maternal weight gain. Note that women who put on more or less weight than recommended had a greater rate of cesarean birth. This is also similar to the findings from Dr. Chen's group. I hope that by this point I have proven to you that a woman's physical characteristics will determine their inherent risk. However, remember that the risk of cesarean birth is not only determined by a woman's inherent risk, but will also be affected by the labor management strategies used by the obstetrical care provider. So let's look at some labor management strategies. Some obstetrical care providers induce most of their patients. Some will use fundal pressure, a vacuum, or forceps. Some jump to cesarean birth at the first sign of a problem, and some are more patient than others in allowing labor to progress. Some obstetrical care providers strongly believe that labor is less likely to end in a cesarean birth by using care that supports the normal physiology of labor. Other labor management strategies include augmentation, early admission, continuous fetal monitoring, the use of epidural anesthesia, and adherence to the Friedman curve. This brings us to other risk factors for cesarean birth. I believe that these factors don't actually affect the ability of the baby to pass through the birth canal, but rather patients with these factors have increased inherent risk or applied risk as follows. Hypertension comes with an increase in inherent risk through induction of labor, fetal size smaller than 2,900 grams, and pre-labor cesarean birth. Gestational diabetes comes with an increase in inherent risk due to both maternal and fetal factors, as well as the risk of induction. Maternal education remains a mystery to me. How does the uterus of the baby know how smart the mother is? Does drinking too much beer in college cause the uterine muscle to become flabby? I think that once there is an accounting of inherent risk, we will find that education is no longer a risk factor. Lastly, maternal insurance. Really? Does the uterus of the baby care how much the obstetrical care provider is getting paid? Payment only matters to the obstetrical care provider, so it may not come as a shock that once there is an accounting of inherent risk, this risk factor is actually applied risk. Now that we have a better understanding of inherent risk and applied risk, we can go back to our most important rule. This equation shows us that in order to determine the applied risk, we need to know the cesarean birth rate and the inherent risk for the group of women that are giving birth. The cesarean birth rate is easy because it is a known number. The inherent risk of a group of women is equal to the average of the inherent risk of each woman in the group. Therefore, all we have to do to create an accurate cesarean birth measure is figure out how to accurately assign an inherent risk for each woman in the group. Once we know the inherent risk, it is simple math to calculate the applied risk. Inherent risk is calculated for each woman by finding a cohort of 100 similar women in our database who have given birth in the same state. Or in other words, the inherent risk for a woman giving birth is assigned based on what has already happened to 100 women just like her. Similar means that the cohort of women will be similar in these 8 characteristics. This is how the Birthrisk Cesarean Birth Measure accounts for all 8 of these risk factors. Contrast this to other cesarean birth measures that only account for age, parity, or perhaps nothing at all. If in the cohort of 100 similar women there were 20 cesarean births, then the inherent risk for that woman is 20%. We then assign an inherent risk to each woman in the group. We can use the average of these inherent risks to create the inherent risk for the group. Now that we know both the cesarean birth rate and the inherent risk for any given group of women, we can solve the equation for the applied risk, and this creates the Birthrisk Cesarean Birth Measure. For example, if obstetrical care provider number 1 has patients with an average inherent risk of 20%, and that provider has a 40% cesarean birth rate for these women, then the Birthrisk Cesarean Birth Measure is equal to 40% divided by 20%, which gives this obstetrical care provider an initial Birthrisk Cesarean Birth Measure of 2. In order to account for changing practice patterns and to create a more meaningful number, the initial Birthrisk Cesarean Birth Measure is then multiplied by the background cesarean birth rate for the time period in which the births occurred. If the background cesarean birth rate was 15%, then the final Birthrisk Cesarean Birth Measure for this provider is 30%. If we compare obstetrical care provider number 1 to the average provider, we find that they are twice as likely to perform a cesarean birth. The unique method used to assign inherent risk gives the Birthrisk Cesarean Birth Measure the ability to provide results by hospital, obstetrical group, or solo practice, and includes all obstetricians, family practitioners, and midwives. I have shown you how I created the Birthrisk Cesarean Birth Measure, but how do we know it accurately measures the risk applied by the obstetrical care provider to their population of patients? The answer is that we must validate that the inherent risk assigned is accurate. To do this, we must go back to our original equation. If the inherent risk and the Birthrisk Cesarean Birth Measure are accurate, then they can be used to accurately predict the actual cesarean birth rate for any given group of women. Validation can only be obtained by comparing the actual cesarean birth rate to the predicted cesarean birth rate. Validation was obtained by taking 182,722 birth records and using the inherent risk for each record and the Birthrisk Cesarean Birth Measure for that provider and predicting the percent risk of cesarean birth for that record using a computer algorithm that does not know the actual outcome for that record. For example, if the birth record had an inherent risk of 20% and the obstetrical care provider had a Birthrisk Cesarean Birth Measure of 2, then that record would be assigned a predicted risk of 40%. But if that very same record had an obstetrical care provider whose Birthrisk Cesarean Birth Measure was 1, then that record would have been assigned a predicted risk of only 20%. Each of the 182,722 birth records was given a predicted risk, and then these records were sorted into 99 groups based on predicted risk from 1% to 99%. The actual cesarean birth rate of each group was then compared to the predicted cesarean birth rate for that group. This is the only accurate method that exists to validate a cesarean birth measure. This graph illustrates how accurately the Birthrisk Cesarean Birth Measure was able to predict actual outcome. The accuracy of the predictions confirms the accuracy of the method used to assign inherent risk, as well as the method used to create the cesarean birth measure for each obstetrical care provider. The Birthrisk Cesarean Birth Measure is the only cesarean birth measure available that provides validation of its accuracy. I would like to thank you for taking the time to view this presentation.